Okay, we're going to get started again. So we have George Mensa and Inka Sastala, who are chairing the session. George and Inka, take it.
Okay, thank you, Terry. Welcome back, everyone. So we have our first talk this afternoon is virtual. So we have Dr. Roshini Abraham from Ohio State University, and the title is, or maybe it's different than what I have, Current Status of Clinical Use of Host Genetic Information. No, wait, it's The Evolving Landscape of Diagnostic Immunology, Past, Present, and Future. Roshini?
Yes, hi, can you hear me?
Yes, we can hear you. Go ahead.
Okay, thank you. I apologize that I cannot be there in person. It has been a wonderful day so far, and I'd like to thank Terry and all the members of the planning committee and the moderators for having me as part of this session. So I oversee a clinical diagnostic laboratory, and so I've been asked to talk a bit about how the clinical laboratory, particularly the clinical immunology laboratory, plays a role in the diagnosis of these inborn errors of immunity. And I think from all the talks we've heard today thus far, it's quite clear that our understanding has evolved with regard to these inborn errors of immunity. We've gone from a Mondrian concept to a Pollock concept. And so that requires that in the clinical laboratory, in the diagnostic setting, that we have a range of tools available to help clinicians with diagnosis and monitoring of these patients. And I know the title evolved a little bit, and it was talking about diagnostic testing, past, present, and future. And we've come a long way, I think, in the clinical diagnostic immunology laboratory, but we still have a ways to go. And when we think about clinical testing, particularly immunology testing, we always have to think about our reference cohort, much like one word in the genomic setting. And this is an area that hasn't received much attention in the clinical diagnostic laboratory in terms of developing robust reference cohorts, because there's so many different factors that can influence the immune response, both phenotypically and functionally. And I feel that this is an area that we ought to pay more attention to in terms of developing robust immune profiles across the age and taking all these variables into account, because we use this data to interpret patient data. And when we also think about clinical diagnostic laboratories, and when I say clinical diagnostic laboratories, I specifically mean immunology and not chemistry, microbiology, and all the other clinical labs. We think of it, it's good to think of it like a pyramid. You know, the base is broad, and as you get to the top, you've got fewer and fewer. So you've got a lot of clinical diagnostic labs that offer some basic immunology testing, whether it be lymphocyte subsets, immunoglobulins, etc. And then as you keep climbing the pyramid, you come to fewer and fewer labs offering more and more esoteric testing that is not widely available. But the goal of bringing tests into the clinical diagnostic immunology lab is to make it broadly accessible to physicians and also to meet all the stringent regulatory requirements that various regulatory bodies, including the FDA, requires. And I don't think it's well appreciated all the time, the amount of money and resources that it requires to validate a single clinical test, an immunology test, to bring it into the clinical domain. And that's partly why the whole clinical lab immunology enterprise is shaped like a pyramid rather than a square or a circle. So what I hope to do today is to use some of the tests we have developed in the clinical laboratory domain to either functionally evaluate variants of uncertain significance in IAI genes, or to help physicians identify targets for immunotherapy, etc. So I'm going to start with this particular case. And that is a 13-year-old male who was referred to our hospital in Columbus, Ohio. He had a history of recurrent infection since early childhood, but his first pneumonia was the year prior at the age of 12. And when taking his history and looking at him phenotypically, he was found to have microcephaly. He also had microcephaly at birth. He had normal immunoglobulins with IgA, selective IgA deficiency at the time. He had a normal karyotype, etc. And he had some genetic testing. But he was referred to our hospital because he developed the pneumonia and he had another immunological evaluation elsewhere and was now found to be profoundly hypogammaglobulinemic. But he also had some increased IgM levels, absent vaccine responses, and some B-cell lymphopenia and NK lymphocytosis. His T-cell counts were normal. So he underwent genetic testing, which identified compound heterozygous variants in the gene encoding the Nibrin protein associated with Nijmegen-Breakitt syndrome. And he had one of the variants, which was a Slavic founder variant, the 657 661 deletion, which he inherited from his mum. And he had another variant that was novel but considered pathogenic, which was present in his father. His father was adopted, so there was no real family history on the father. So I had started developing a test to look at DNA double-stranded break repair response when I was at the Mayo Clinic. And when I came to Columbus, I completed the validation, moved it into the clinical laboratory as a clinical test. And in this particular assay, we look at phosphorylation of three key proteins that are associated with the DNA double-stranded break repair response, which includes phosphorylation of ATM after induction of DNA double-stranded breaks, as well as phosphorylation of the histone gamma H2AX. So you can see that he has some impaired phosphorylation of ATM, but his gamma H2AX looks normal. However, when we look at the kinetics of the DNA double-stranded break repair response, we find that, and this is data from his T cells, but his B cells and NK cells looked exactly the same, and that he had failure to dephosphorylate the gamma H2AX, indicating that DNA double-stranded breaks were unrepaired or there was ongoing DNA double-stranded break damage. And if, for those of you who may be familiar, Nibrin is one of the key proteins involved in DNA double-stranded breaks, both due to homologous and non-homologous end joining. So it was quite clear, and phenotypically, actually, he had the classic bird-like faces as well. So it's a rather a bit of a shame that he was diagnosed only at 13 years of age and not early in life. And as I was wondering, what this meant for him, because I was concerned that he might wind up getting a malignancy. Well, 4 weeks after that diagnosis, he was found to have a T-cell lymphoma, and for which he received chemotherapy. But the problem was after chemotherapy, he got multiple bacterial infections, which were treated, but then he developed pulmonary aspergillosis with necrotizing pneumonia. And so the clinicians, the ID clinicians, reached out to me and asked if I could help do some immunophenotyping to identify whether he might be a suitable candidate for immunotherapy. And so based on long-standing evidence, as well as some work I'd done at the Mayo Clinic, I'd looked at HLA-DR expression of monocytes, because the loss of HLA-DR and monocytes is associated with a state of immune paralysis. And so this boy had low DR expression of monocytes. And so it was determined based on the NETIA protocol to treat him with recombinant interferon gamma. And then we measured changes in HLA-DR expression. It went up and down over a bit, but then stabilized by what I refer to as time point 11 over here. And then by then he was clinically much improved. He was discharged and had recovered from the aspergillosis. And we've had a few different patients where we've used this approach of looking at DR expression of monocytes to identify individuals with immune paralysis and to select them for treatment with recombinant interferon gamma to sort of reverse this scenario of immune paralysis. Now, from a laboratory perspective, there are many different assays one can do. One can measure HLA-DR expression on CD14 monocytes and look at the median fluorescence intensity. or one can do it actually a little more robustly by using what we call molecules per cell quantitation to actually try and analytically standardize the measurement of this particular marker across clinical laboratories. But regardless of which way one does it, this is a potential way of identifying patients who might benefit from treatment with recombinant interferon gamma therapy or GM-CSF in the context of refractory infections. My second example is a 2-month-old female who was referred from the outside, who had hepatosplenomegaly, failure to thrive, identified to have pseudotorch syndrome, and USP18 deficiency, which is a type 1 interferonopathy, is associated with pseudotorch syndrome type 2. And she was found to be a compound heterozygous, with one of her variants being a frame shift and the other a missense. And so a couple of years ago, I had developed a test in the laboratory to quickly assess the type 1 interferon signature on CD14 monocytes. I can, during the discussion session, explain why I chose this particular marker. But long story short, I was looking for a marker that was easily accessible to physicians, that I could turn around rapidly and do it on whole blood, on a small amount of whole blood. And not surprisingly, this patient had a strong type 1 interferon signature with strong expression of Siglec-1 or CD169 on the majority of her monocytes. And she was started on treatment with JAK inhibitor therapy, and we've been monitoring her periodically since. She did show an improvement after 4 weeks of JAK inhibitor therapy. And I'll show you some data in a moment, but we also see a type 1 interferon signature in the context of viral infections like COVID-19. But these signatures tend to be transient, as you can see in the example below. This is a patient during the middle of a COVID-19 infection. She had a strong type 1 interferon signature, which resolved within 6 weeks, and then even 9 months later, she was essentially normal. So in part with that assay that looks at type 1 interferon signature, I also look at a type 2 interferon signature using a marker called PDL1 or CD274 on monocytes. And here's an example of a young male with hepatosplenomegaly, elevated ferritin, soluble IL-2R, etc., who happened to have perforin deficiency HLH. And so as we were getting ready for transplant, the decision was made to treat him with emapalumab. So I looked at a number of different markers to look at CD274 expression. And as you can see, PDL1 is a molecule that is induced by interferon gamma. And so you see a strong interferon gamma signature on this patient, which is also supported by the CXCL9 levels that are high after treatment with emapalumab. That normalized, and he was slowly starting to drift again when he had his transplant and has now been stable. We also look at some cellular biomarkers in these HLA patients because they have increased activated T cells, particularly in the CD8 compartment that express HLA-DR and CD38. So we use a number of different markers to evaluate our HLH patients. We use this PDL1, CXCL9, the activated T cells, and we use that to both diagnose as well as monitor response to treatment. And this particular child had a male sibling who was also affected, who unfortunately died of COVID-19 prior to transplant. So I've looked at about 600 patients with a variety of clinical contexts for both type 1 and type 2 signatures, and about a quarter of those have a positive type 1 interferon signature. As you can see over here, far fewer patients have a type 2 interferon signature, and most of these are HLH patients, though there are some patients with some autoimmune cytopenias, etc. And we've looked at ROC curve analysis and found that you can get really good sensitivity and specificity of CD169 for type 1 interferonopathies, a variety of them, with the cutoffs that are shown over there, and the same for CD274. So I won't go into the details of the type 1 interferon pathway because you heard a little bit about it from Ryan in the previous talk. But nonetheless, there are many different pathways of type 1 interferon induction and receptor signaling. And there are about 38 monogenic or Mendelian disorders associated with type 1 interferonopathies, and about 17 of those are associated with to do with nuclear acid substrates. And there's been some data to suggest that Aicardi-Gouttière syndrome has been identified by newborn screening for X-linked adrenoleukodystrophy. Aicardi-Gouttière syndrome is a prototype type 1 interferonopathy. However, I think there are some challenges with introducing newborn screening for Aicardi-Gouttière that we could discuss later.
Yeah, 1
And-
minute, 1 minute, Roshini.
Yes, almost close to
Great,
being
thanks.
done. And the other is going back to the discussion regarding using combinations of markers. So this is a study from Carl Allen and his group where they looked at different plasma proteomic data and identified certain cytokine or chemokine signatures that could discriminate in context of inflammation between HLH and sepsis. And they showed that CXCL9 IL-6 was a good discriminator of HLH versus sepsis, though, of course, if you added another 8 more classifiers, you could discriminate and improve the sensitivity and specificity. One of the topics that Terry had asked me to briefly touch upon, because this is a topic in itself, is that we are currently under significant threat in the clinical laboratory in all areas with regard to new FDA regulations that go into effect May of 2025. And right now, the FDA is quite implacable. So clinical laboratories are preparing for this. But I think as a field, we stand in great danger of any of the innovation that we are trying to bring into the clinical laboratory being defeated by these FDA regulations. So I think as a mandate for diagnostic and clinical laboratories, we try to improve the repertoire of testing, and we can use that for functional evaluation as well as phenotypic assessment. And oftentimes we find a combination more useful than a single marker, but the regulatory oversight is indeed a significant threat. And as we've heard from some of the lectures today, timing of immune assessment is very important. And patients who are pre-treated, can alter the interpretation of the immune signature. So it's ideal to obtain a baseline. As for the future, well, it's bright or grim, depending on your perspective and depending on whether the regulatory bodies have the final say or not. I'd like to thank the people in my laboratory who try to translate research findings by validating them and bringing them into the clinical domain. And I also thank my former lab at the Mayo Clinic.
Thank you very much, Roshini. We would need about 10, 20, 30 seconds to switch from the remote to Ephraim's presentation, but it looks like we're almost there. By the way, we're not going to hold those last 10 seconds against you, but we're going to count on you getting us ready. No. All right, so Ephraim is going to tell us about the the available technologies for assessing host response. Ephraim, over to you.
Thank you very much. I'm going to start with a little bit of maybe a philosophical preamble before we get into actual technologies, which relates to the way in which we think about technologies and use technologies as clinicians. And I'll just sort of jump in here. Most of you have not been sort of industry, so I didn't know whether I needed a disclosure slide, but there you have it nonetheless. So I come from Danaher as well as on the academic side at Duke and the Durham VA, but Danaher, if you've not heard of it, is a large company that is itself comprised of many companies, some of which you may have heard of, and they're sort of listed there at the bottom. So I'll jump on to Bayes. So diagnostic reasoning is intuitively Bayesian. We think about how likely a particular diagnosis is, and then we initiate testing in order to help inform what our differential is. And a lot of that is dictated by the history. I mean, the history alone can give you a diagnosis in the majority of cases. And then you move on to an exam, and then you move on to testing. And you go through this stepwise process, and ultimately to get to some diagnosis where you have sufficient diagnostic confidence in order to act and take the next step, whatever that may be. And so we intuitively think that way. But that's not, but we don't hold our tests to the same standard. We sort of force clinicians to think in this frequentist way, that this is the way that we do statistics and p-values and sensitivities and specificities. And this then becomes the bar, the standard by which we hold all of our diagnostics. We want things to be nice and simple. We want a troponin algorithm for everything that we do, not just in infectious diseases, but everything. Right? If the patient has had chest pain for more than X number of hours and you do a troponin and it is less than 6, then you're okay to send them home. If it's between 6 and 20, repeated after 2. So we like that. It tells us exactly what to do. Medicine is increasingly complex. And I mean, only going to become even more so as we introduce genomic information and other multimodal information. So clinicians rely on algorithms to help them make sense of what it is that they're supposed to do. But then, when you think about and you ask them, well, how are you using diagnostics? They're not all, most of the diagnostics we use are not troponin-like, which is itself imperfect, although everybody says they want the troponin of infection, the troponin of whatever. And so when we think about what this looks like in the context of sepsis, where is our troponin for sepsis, in sort of the most extreme form of infection? This is a little dated. There's actually a more recent review, but I just didn't bother updating the slide. But these are all of the biomarkers that have been looked at for sepsis. And they divide them up into different physiological measurements, coagulation-related biomarkers, vascular biology-related biomarkers, and so on. And of all of these biomarkers that have been evaluated, they all have some relationship and some correlation and prognostic value in sepsis. And I can tell you that probably, well, 0 of them are used in clinical practice. So clearly, it's not that we need a biomarker. We have biomarkers, so why isn't anybody using them? And I'll highlight a couple of examples of tests that would probably in no way pass muster today. Well, we know they wouldn't pass muster today, but yet are actually utilized. And so how did these tests break through this paradigm? And I think it's largely because they've been around since before any of the physicians using them were born. So they just grew up with them. I could add white blood cell count to this list. Is almost as good as flipping a coin to figure out if you have an infection. But I can't tell you how many surgeons I've said, well, did you check the white count? When I tell them, I'm seeing a patient who has pus coming out of a wound. Well, did you check the white count? Like, I don't care what the white count is. So ESR, right, discovered more than a century ago. CRP, another one, right, that's now almost a century old, that we actually, and CRP is actually used relatively commonly to help guide whether or not antibiotics should be necessary, a little more so outside of the US than in the US. And the reason is because even though these tests, we know implicitly that they're not super specific or sensitive, they still have value. And that's particularly at the extremes. And this is going to be a point that comes up again a little bit later. But if you look at low values of ESR, this is in the context of distinguishing osteomyelitis from diabetic ulcers. But low values and high values can be informative. It's that large number that's in the middle that, of course, is difficult, but that's okay, right? We see a value in the middle, and we kind of shrug our shoulders and move on. But if it's really low, we're like, oh, okay, I feel better about that. Or if it's really high, it can tilt you into that degree of greater diagnostic certainty. So that was my sort of philosophical backdrop. So now let's get into what some of the technologies are. So these are all FDA cleared. I'm only focusing on US, so not sort of IVD or CE mark, or IVDR or CE mark. But these are, and I also will apologize that these are not all genomic or transcriptomic in nature, but they all are host response diagnostics. So this was a relatively recently cleared one. This is actually a lateral flow assay that measures qualitative levels of CRP and MXA. MXA is increased in response to viral infection, CRP in response to bacterial infection. It's nice, it's cheap, 10 minutes, and the indication for use is as an aid. You'll find all of these are aids in the diagnosis of. None of them are definitive. Aid in the diagnosis of bacterial respiratory infection to differentiate from non-bacterial etiologies in essentially adolescents and adults in an urgent care or ED population with less than 7 weeks of acute respiratory symptoms who've also had fever. And this is qualitative, so it's very much a yes/no sort of a scenario, but you can see I'll focus on likelihood ratios, which again sort of speak to how useful these may be, and it's actually pretty good, right? So a likelihood ratio of 8 when positive, 0.08 when negative, and this is specifically to help determine whether or not someone has a bacterial or a viral infection. So not too bad. This is another one. This is the MEMED, an Israeli company that measures 3 proteins, immunoassay proteins. These are quantitative. And those 3 proteins, those levels are fed into an algorithm that then gives you a score. And that score essentially correlates with the likelihood of infection. And the score is basically from 0 to 100 over here you sort of see on the left. And now we're kind of getting into that stratification, right? Where if you look at patients who are in the highest band, you have a likelihood ratio of 34. And in the lowest band of 0.1. But again, you've got a large number in the middle, but even so, there it's fairly decent, 5 and 0.13 in terms of positive and negative likelihood ratios. And only around 10 to 15% of patients fall into that middle category that's sort of considered indeterminate. This is an interesting one. This is host response as measured in sort of a cellular biomechanical form. So as patients deal with infection, their white blood cells become activated, and macrophages and monocytes in particular. And so what they do is they almost create like a little flow cell. They pass blood cells, and then they exert an external pressure on them, and they look at the squishability of the cell. And over on the left, you can see what sort of a normal white blood cell would look like if you exerted some pressure on it, and what a sepsis patient white blood cell, how it might become deformed in the context of that external pressure. And they use that essentially as a biomarker for the presence of infection. And so their indication is an aid in the early detection of sepsis with organ dysfunction arising within 3 days of testing in patients showing up to the ER. And you can see similarly, they have these bands, 1, 2, 3, and depending on which band you're in, the likelihood ratios go up. Here, maybe not as compelling as what you saw before, a negative likelihood ratio of 0.31, a positive of just under 3, but even so, an added tool. Good enough to get adopted into use? I don't know, time will tell. Similar sort of concept, this is the sepsis monocyte distribution width. Here they're looking at the distribution of size of monocytes in a population of cells, which increases due to cellular activation in context of sepsis. And here, similar sort of indication to identify patients at increased risk of developing sepsis within 12 hours of presentation. And then here, there is only a single cutoff. You don't have bands, but you could see in when the likelihood ratios, if you're sort of above that level, 2.4, below that level, 0.3. Or the point estimates, around 2.5 and 0.3. Now we're getting into gene expression, and you'll hear more about a gene expression approach in the next presentation as well. But here, they're measuring the levels of 2 genes. One is upregulated in sepsis, and one is downregulated in sepsis, and they combine those to basically create a score, which, as before, gets broken up into 4 different bands. And you can see, in this case, these are the probabilities of having sepsis, depending on which band you fall in. So it's worth noting that if you look at patients in band 4, 20% of patients who test positive in band 4 won't have sepsis, and 11% of patients who are in band 1, the lowest likelihood of sepsis, will actually have sepsis. So most people would look at this and say, well, wait a minute, you're going to give me a test that's going to tell me that I'm going to miss sepsis 11% of the time? I'm not willing to accept that. But again, they forget that what they're already doing is so bad that this has got to be an improvement. But one thing to note, this is, I think, sort of interesting, is these signatures were largely derived in patients from Utah and the Netherlands, so you can think about what they have in common. But if you just take a bunch of healthy Black individuals, more than a third of them will test positive for sepsis, completely healthy. And slightly lower, but still perhaps unacceptably high population of Asian background patients will test positive for sepsis. So again, something to note in terms of the derivation of these things. This was an interesting one recently cleared by the FDA. This is a clinical decision support tool, and they basically take more than a dozen different parameters that you can identify in the medical record, as well as some biomarkers, and create effectively a score or a likelihood of somebody having sepsis or progressing to sepsis within some period of time of presentation. And here, again, your likelihood ratios on the low end, 0.13, on the high end, 15, it's pretty good. But again, it's going to be a fraction of all of the patients that you test are going to fall into either of those bands. Okay, a little bit of a preview of what's coming. In the bacterial versus viral space, there's a lot of activity. I won't go into each of these, but the one on the left, inflammatics, is what you'll hear about in the next presentation. Cepheid, one of the Danaher companies, is also developing a gene expression tool for bacterial versus viral discrimination. And another company, Biomeme, had previously been affiliated with, also developing one. I just want to spend a moment talking a little bit about sepsis, and this isn't necessarily a product, but rather an area that I think is very exciting. I was hoping I'd have time to go to it, so I'm glad I do, unless I'm told otherwise. Oh, perfect, okay. So one of the inherent challenges, and probably one of the reasons that large table or slide of many different biomarkers have failed in sepsis is because they treat sepsis as a monolithic disease. It would be like saying, I'm going to create a single test for cancer and expect to identify all cancers, and based on that one test, I'm going to treat all cancers with one drug. It's bound to fail. And the same is what we think is the reason that things have essentially failed in the context of sepsis, both from a diagnostic as well as a therapeutic perspective. Sepsis is a syndrome. It is not a singular disease. And if you then assume that it is, and you treat everybody with the same drug or try to diagnose everybody with the same approach, you're going to find that some people might benefit from a particular treatment, some might be harmed, and there's probably a lot of people who derive no benefit at all. And so a clinical trial ends up showing no effect. But what we're finding through a lot of research that's going on is that if you now start to try to define some, basically the biological phenotypes that naturally occur within a sepsis population, now you can develop a potentially new strategy. And so there's different terms, there's some nuances in terms of whether we're looking at endotypes or subphenotypes or subtypes, but it's the same general idea of looking for characteristics that naturally segregate patients or subpopulations with sepsis.
2 minutes.
Okay, perfect, thank you. There's a number of papers that have started looking at that. I've only focused on ones here that utilize gene expression or transcriptomic approaches, and more continue to come out. And there are also others that have looked at coagulation markers, that have looked at clinical variables. So there's a lot of different modalities you can use to get to these. This is just one published by a group at Oxford that we're collaborating with. They essentially did transcriptomic studies and found that there were two, depending on where you created the cutoff, 2 groups that they sort of categorized it in. But you could probably almost see 3 or 4 different groups that these patients fell into. But they created the cutoff at a high level, identified 2 subgroups, and then that was all done unsupervised. And then they said, well, is there any clinical relevance? And sure enough, one group has worse outcomes than the other. But you couldn't have predicted which group any given patient fell into based on their clinical characteristics. And then they did something which I think is really compelling, which is they looked at, in a post hoc manner, at a clinical trial of patients who got steroids or placebo. There's a lot of controversy as to whether you should use steroids in sepsis. Some studies show a mortality benefit, some show an increase in mortality, most show no effect, and there's a lot of uncertainty. So the punchline is that when they compared, they looked at these sepsis response signatures among patients receiving placebo, and they found that the one group that generally has worse outcomes, SRS1, indeed had worse outcomes in terms of a lower survival. When they just focused on SRS1 patients, they saw no difference between placebo and steroids. But when they took the group that generally had a better outcome and they got steroids, their mortality went way up, lower survival. So they demonstrated a heterogeneity of treatment effect or a treatment interaction effect between this underlying immune profile as measured by gene expression and steroids. And there's a lot of reason to believe, and there's precedent in other critical illness syndromes like ARDS, that there are a lot of treatments that you can utilize that can demonstrate that heterogeneity of treatment effect when you find the biomarker that helps to now stratify your sepsis population. And just to highlight the fact that this isn't just theory, but this is actually being put into practice, these are the clinical trials that are either active or going to be starting within the next 12 months that are taking a precision medicine approach where they identify biomarkers to stratify patient populations and then essentially treat them and look for that heterogeneity of treatment effect. Another area of future development is in companion diagnostics in infectious disease. These are, again, biomarkers. that are linked to specific treatments that target the underlying biology. And these are both targeting innate immunity, vascular integrity, as well as the angiotensin pathway. And there's a lot of preliminary data to suggest that this is likely to be a successful approach.
You frame it, Meona. Very good.
This is perfect, man. This is perfectly aligned. Thank you. So, so really, the conclusions are almost taking a step back. One of the challenges that diagnostics developers have is in developing diagnostics that are going to be received by clinicians who've been trained to fight against their Bayesian nature when they look and evaluate and decide whether they want to adopt diagnostics. I'll highlight, and you know, again, I don't know whether Pravesh is going to talk about the timeline that it took them, but from the time of discovery to actually developing these tests, you can at least a decade. So we're really just now starting to see these tests emerging on the market. Host response is a great tool to answer a variety of challenging clinical questions, but ultimately, creating a test doesn't mean that people are going to use it. Just because it's there, that doesn't mean it's going to be helpful. And so we're adding that additional layer of expecting clinical utility studies to demonstrate the evidence that ultimately is going to be needed to drive reimbursement and adoption. I think that's it.
So we already had a teaser about the next talk.
Yes.
About translating host response-based diagnostics to clinical practice by Pravesh Khatri.
All
Go
right.
ahead.
Thank you for having me and be a part of this wonderful talk, wonderful workshop. And thank you, Ephraim, for setting up the stage that I could get rid of so many slides. So thank you very much. Now, today I'm here as somebody with feet in both academia and industry. I'm a co-founder and a chief scientist for Inflammatics, but I'm also a professor in Department of Medicine at Stanford. And my disclosures, I'm going to talk about Inflammatics related work here. So because everybody else has talked about the difficulty in diagnosing infections, I'm going to talk about why host response. And probably everybody in this room knows this study by Jen et al. In New England Journal of Medicine. All pathogen detection-based tests that were tried across 9 different clinical centers in patients with radiographically confirmed pneumonia. So this is, we knew that they had infection, 62% of the people, no pathogen detected. And then the question becomes why? And the answer to that is immune system. One thing that immune system has been evolving for millions of years is to make sure that any danger signal does not become systemic. That's its one single job. If there is a danger, make sure it's quarantined and get rid of it. And if you had asked me, like Stephen was saying 30, 40 years ago, if you had asked me 20 years ago, I would have said I'm an electronics and communications engineer, not a professor in medicine or an immunologist. But during my postdoc, I started to learn about immune system. I was in organ transplant lab. And turned out that immune system has had this really privileged status during the evolution, right? This is the only organ system that has exclusive access to all other organs, except brain. But then brain is not mobile. Brain has to stay in one place. Immune system's allowed to go walk up to every single organ, surveil, and look for danger signal. It can also expand and collapse as needed. When there is infection, B cell, T cell, monocytes, they all expand. Infection goes away, they contract. We think about evolution over millions of years or thousands of years, but immune system in each one of us is evolving continuously over our lifetime. It's the fastest rate of evolution. And it has memory. It remembers what it saw since you were born until the day you die. So this ability of immune system, this privileged status, basically means that we should be, instead of looking for a pathogen, which immune system is explicitly designed not to let it become systemic, otherwise you get sepsis, why don't we ask immune system, what are you looking at? Because it knows over the evolution, it has learned what is bacteria, what is virus, what is pathogen, what is fungi. It knows it, so why look for a pathogen? Why don't we ask immune system, what are you responding to? And what that means is when a completely new pathogen emerges, immune system can actually tell us what bigger group it belongs to. And then, as some of the examples Ephraim showed, we could also do risk stratify, treatment prediction. We should be able to do all of this. But the problem is we need to be able to do this very quickly, 30-minute turnaround time at point of care. So the problem in measuring immune host response, and now I'm not talking about genetic response. Roshni had a fantastic slide of all the factors that affect immune response, and genetic information was one of, I think, 10 or 12 different factors that she had, and most of those were epigenetic risk factors: age, sex, comorbidities, lifestyle, all of those things. And that is reflected in the real-world patient population, right? We don't get patients only with genetic mutations. We get patients that have different comorbidities. They are different age. They present at different point of their infection. The lab results are not really clear. And any test that we develop based on host response has to work in this very broad immune variation. The other problem is the clinical context also matters. Some patients will have a community-acquired infection, whereas another group might have a hospital-acquired infection. So when you develop these diagnostics, they actually have to work. If you want to develop one diagnostic that works across different clinical contexts, it really has to have these non-linear decision boundaries. And then the question becomes, how do you do this? Do you do single cohort analysis, multi-cohort analysis? And that's where data that exists in public domain becomes very useful. And really, NIH has done this fantastic job over the last 20, 25 years, right? Of all the data that's funded and generated by NIH becomes available in public repositories. And everything that we've done is using this public data. So no data was generated for the discovery. Everything is publicly available data. And not because, as one of my very dear friends says, I'm cheap, lazy, and parasitic, but because I'm frugal, efficient, and symbiotic, right? It's a point of view. But the real point is these individual studies where there is inclusion-exclusion criteria to make studies more or less homogeneous, collectively, they represent the real-world patient population heterogeneity. They come from different countries, different genetic background, different age, different comorbidities, different technologies, different stages of disease, different severities. Think of a traditional confounding factor, and it's present across different studies. If you can somehow combine this into single analysis, then we are off to races, because now we would have very generalizable diagnostics. And that's what, as a computational person, we've developed a lot of methods to actually leverage this heterogeneity, not as a curse, but a blessing. That data already exists. We can directly go and start using it. So we've basically, over the last 10 years or so, our overall analysis is about 25,000 samples, more than 100 independent cohorts coming from all 6 inhabited continents, more than 30 countries, all of that going into a single analysis to say that there is a set of 29 genes where a different set of genes do different things, but they can diagnose presence, type, and severity of infection. All of those signatures combined using machine learning AI into single classifier that can now, when a patient presents with an acute febrile illness, we can diagnose whether they have infection or not, what kind of infection, and what is the severity. But there is another problem, and that problem 10 years ago was every time we tried to license this, I never thought I would be a co-founder of a company, was that somebody would come in, license it, and we can go on and keep writing our grants. And then nobody licensed it. And it took us a while to realize that the problem is we had 29 genes, and there is no platform that could measure 29 genes, high multiplex, in 30-minute turnaround time at point of care. So that's where we decided to say, if nobody else is going to do it, we are going to do it. So we started Inflamatics. And to answer Ephraim's question, sort of jumping off of that, it took us about 7 years to build this device, but now we have a device that has 30-minute turnaround time with less than 2-minute hands-on. So the only manual work required is taking the blood sample in a PAXgene, putting the PAXgene into this cartridge, and then putting the cartridge in the machine and following the on-screen prompts. Takes about 30 minutes to measure up to 64 genes. Right now we are measuring 29 genes, 32 genes total in duplicate, including housekeeping, but it's fully automated. And the results are 3 scores. So it's not 1 score, it's 3 score with 5 levels each. It's a probability of viral infection, bacterial infection, and a probability of requiring ICU level care in next 7 days. You get 5 bands for each of those, but collectively these 3 scores along 2 axes is what a clinician is looking for. Is this infection? If both either viral or bacterial or both scores are high, then you know that it's infection. But what if it's low? Then you know that it's not infection. Maybe it's something else, and you can start thinking about other diagnostics. And then the severity, which basically tells you whether they should go to ICU or you should do additional diagnostics and you could send them home. So overall, 3 scores along these 2 axes allows presence, type, and severity of infection. Does this really work? So this is the registrational trial that is under review by FDA. All of the data is in this manuscript that's currently under review as well, but it's on the Research Square in public domain. And I'm just going to give you top-line result that each of these 3 scores, so first what the trial is, it's over 1,200 patients across 22 different sites. The inclusion criteria are here. That's basically all ED presentation, either suspected infection and 1 abnormal sign, or a blood culture order placed and 2 vital signs abnormal. And what you see is basically the same result as Ephraim was showing, but you see that when bacterial score is really high, band 4 and 5, the red band, you essentially get specificity more than 90%, meaning when they are excluded from not having bacterial infection, 90% of those would definitely not have bacterial infection. That's band 4 and 5. And sensitivity is, again, 97, 87, 81% in the lower band. In terms of likelihood ratios, that translates to over 5 or less than 0.1 for all of those. Just a few more comparisons compared to, for example, procalcitonin. And this is another thing that Ephraim was showing, how accuracy changes depending on the patient population. So Triverity, the inflammatics test versus procalcitonin, overall, Triverity head-to-head more accurate. But as you break it down by different patient population, PCT has a higher accuracy in whites compared to black or African ancestry and all the other races. So compared to Triverity continuously maintaining that same minimum accuracy. And that is what, because of large amount of heterogeneous data that was included upfront. Same thing goes for severity. Substantially higher sensitivity compared to, for example, lactate. Overall, in terms of what is the value created, what are the advantages if it is implemented in clinical practice using this 1,200 patient trial. So just look at the last column, reducing antibiotic usage by about 65%, missed bacterial infection, picked up about 80% of those. False negative, these are the ones that all the lab tests looks good, clinicians send the patient home, and we were able to pick up because those patients had band 4 or 5 in terms of severity, that ultimately those patients ended up requiring ICU level care that were actually at presentation were not that severe.
2 minutes, please.
Thank you. I'm almost done.
Great.
And then just one, this is not part of the paper that I showed you, But as Afram was showing, that maybe you diagnose, so what? What should we be doing with these patients? As Afram again mentioned, there is a lot of discussion whether steroid hurt or benefit sepsis patients. So this locked classifier for Triverity with the severity band. So the classifier is locked, thresholds are locked, and we simply applied that to first Victus. This is a randomized controlled trial for head therapy. And we simply a priori decided that band 5, which is very severe, sensitivity specificity is in 95% in terms of requiring ICU level care. If you look in that group versus the other 4 group, what you see, and this is a small study, so sometimes you don't reach p-values, but you see that if you are in band 1 through 4, so less severe, and do not get steroid, nobody dies. Giving them steroid, mortality higher. Versus band 5, there is benefit in those who are really severe. This is one study. Can we reproduce an overall hazard ratio after correcting for everything really significant? So then the same study that Afram was showing, Vanish trial, exactly same threshold, log classifier, same band 5 result, and you see exactly the same result. If you are not severe and you get steroid, we are harming patients. If you are severe, band 5, and you get steroid, those patients benefit. So really, we are starting to bring, now we call this Triverity because it was present type and severity, but there is a potential that this could also start giving us information about who should be getting treated and who might benefit, who might be harmed with the same thing. So it could be Quadverity instead of Triverity. I'll end by summarizing what we started out about 10 years ago, thinking that immune system can do it. And now we are expecting FDA clearance sometime next month for Triverity that can now detect any any infection. We can re-stratify patient, make treatment prediction, and you can get answers in 30-minute turnaround time with a single blood draw. This has taken a lot of people. This is not the list of all the people in the lab who do all the work and allow me to say Royal V did this. People at Inflammatics, this has been really, wouldn't have happened without all of these people really spending all this time. Thank you.
All right, we are at the finishing line here. So the very last presentation will be given by Morgan Similik from the NIAID. And we're talking about bridging the gap, addressing obstacles in genetic counseling for immune disorders. Morgan?
Okay, great. Thanks so much. We've made it to the end of the day. Congratulations, everyone. So Terry invited me to talk about barriers to genetic counseling. I'm the lead genetic counselor at NIAID and co-lead our sequencing program along with Magda Wakowicz. And I'm going to do that, but looking at the agenda, it also looked like there would be an opportunity to talk some more about the experiences on our group, as well as incorporate some of our patient-reported outcome data and other aspects of patient voice in the conversation today. So let's see, forward. So I thought I'd do that and then wrap up with what I see as gaps and opportunities. So to get everybody on the same page right off the bat, genetic counseling is a process of helping people make meaning of genetic information and then use that information in a way that's consistent with their values, needs, and wants. And when it comes to barriers to genetic counseling, that's largely coupled, especially in the immunology space, to barriers to genetic testing. And I'm showing here a high-level graphic summarizing that these barriers exist on multiple levels for providers, for patients, baked into the healthcare system. And we've heard from many people throughout the course of today that there's several different clinical pathways to genetic testing. Sometimes this happens in the NICU PICU. Sometimes this happens through a multidisciplinary care team. Sometimes this happens through the genetics department or through an individual immunologist. And you can appreciate how, depending on what the pathway is, there's a different a different mix of barriers that are at play. One of the other things that I want to point out here is that there are likely also some special barriers related to the capacity and comfort in the genetic counseling community with disorders of the immune system. In our professional status survey, there's a handful of genetic counselors, I think several of whom are on our team, who say that immunology is their primary practice area. And then there's a few dozen across a cohort of several thousand genetic counselors that say that they see any immunology patients at all in the course of their practice. And so there's just not a ton of experience. And I think there's some easy wins in the short term to make available more resources than there are at present for the genetic counseling community. One of the last things that I want to add here that I haven't heard in the conversation so far today, but it's really important and it isn't unique to immunology, is that Dusan's group, but others as well, have published on persistent and substantial racial disparities in access to IEI diagnosis, and also that these minoritized groups are more likely to be hospitalized, minoritized groups with IEI more likely to be hospitalized. And so in our conversation today and tomorrow about implementation of genomics, I think all of us agree that we want to do that in an equitable way and to continue to keep that perspective in our conversation. So this combination of barriers and just shouting out that motivation for any individual case is also in the mix determines who is receiving genetic counseling for immune disorders across the country, and it's not very many people. And at NIAID, we've been able to experiment with exactly how we triage the genetic counseling resources in more rational ways, and I'm going to circle back to that story in a little bit. So to pivot now to talk about our program, which Magda's going to talk about at greater length tomorrow, I've highlighted in the upper right here our current team of genetic counselors, and this group of people sees patients mostly for immunology-related indications every day of the week, in addition to patients who have other indications. Other indications for testing. And in addition to that clinical care, our genetic counseling group is involved in a variety of activities that I've highlighted on the right side or the orange side of this virtuous cycle that many of you all published several years ago that have to do with understanding how to best improve the quality of clinical care for genomics that we provide to our clinical research participants. So this includes just sort of day in, day out quality improvement strategies, practice innovations, and asking the questions, designing the research, collecting the data to provide an evidence base to inform when we try something new about how we implement, how we return results, how we enroll people, to provide the evidence base about how to do that work better. And this story, of course, starts where it always should, by listening to our patients. So especially when I began practicing in this space and knew very little about immunology, it was really important to me that I listen and that I listen well to our patients about their perspectives about their illness, about their priorities, about genetics and genetic testing. And I did this through a series of systematic reviews, interviews, and surveys. And like all of the cases that people have shared today speak to, and also just clinical practice, and to summarize this work with just the very broadest of brushstrokes, these disorders, of course, have the potential to have substantially negative impacts on our patients' lives, both the quality and the quantity of the years lived for our patients. And to say this in the words of one of our interview participants, she said, "I felt very cheated. I was supposed to go to law school. I was going to do the Peace Corps. I had all of these plans and things didn't work out for me. I've watched my peers moving forward in their careers and starting families, and I felt like my life was supposed to be different. It's been very hard for me to reconcile myself to the fact that this is the way things are for me." And yet, as we all know, most of our patients over time adapt or psychologically adjust to the challenges of their immune disorders. This adjustment or adaptation is complex and ongoing and requires frequent recalibration to the new challenges that emerge as they move through different life stages. Our patients evaluate their quality of life in a multidimensional way that's more than the sum of their symptoms, and they speak to, in interviews and the qualitative work that's been done in this area, to the roles of hope, finding a sense of control and paradoxically relinquishing that control, and the potent positive or negative impacts of the social interactions in their life. To say, in the words of another one of our participants, everything that's happened to me has made me who I am and made me this very determined person. Regardless of anything that goes on, I can do anything I want to do with this level of determination and the amount of fight that I've got. And if you will, it's been in fact these experiences that have given it to me. I've almost died countless times. I've been on gurneys. I've had tubes hooked up everywhere and everything like that. And no amount of stress at work or anything is ever going to put me back in that situation. So now there's nothing that I feel like I can't get past. Speaking to the capacity our patients have to navigate these challenges. Lastly, many studies show us that anxiety, comorbid anxiety and depression are prevalent and consequential for our patients, and they want us to recognize that in them and address that with them. Layer on top of that work on illness experience, we know from our patients that genetic diagnoses matter to them. I've pulled out from some of our surveys and interviews just a couple patient comments to the question, what's been most helpful in learning to live with your illness? And you'll recognize here concepts related to having a name for their condition, having a disease community, having more targeted treatment, the alleviation of guilt that they felt from their disorder. And this qualitative work is in fact further supported by quantitative validated measures of patient-reported outcomes stratified by genetic diagnosis status here, where the patients in orange are the ones that have a genetic diagnosis, and by almost every measure have better self-reported outcomes or faring better compared to those without a genetic diagnosis. And here we're capturing their perspectives on things like being able to explain their condition. And that sounds like a simple thing, but I think this type of thing is very meaningful to our patients, to be able to say to a neighbor or to be able to respond on the playground when someone says basically like kind of what's up with your kid, to be able to have a coherent response and have the sense of competence that that can give parents or individuals about how they're navigating their illness. Most importantly, though, people with a genetic diagnosis in this disease community have a greater sense of being able to make decisions that change their future, which is really important, and also a better ability to know who's at risk in the family. And it's in fact that familial dimension of these disorders that have always been of great interest to me, and I think are in fact an unsung complexity of our patients. And as we were talking about earlier, particularly with some of the dominant disorders where there's reduced penetrance and marked variable expressivity, this can be really complex for people. As you all have seen, I'm sure in clinic, genetic diagnosis prompts a sort of iterative reconceptualization of family ties and disease risk, of understanding who might be at risk, and also the spectrum of what it means to be affected. Maybe for a patient, they've been really sick their whole life, but now they're looking at their cousin who has type 1 diabetes with new eyes, thinking, is that possibly a manifestation of the same disorder? In the words of one of our patients on this topic, she said, my whole life I wanted to be a stay-at-home mom, and then when I was 21, I got sick and I went on medication, and my doctor said, no, you can never go off this medication, but I also couldn't be pregnant on it. And that was really hard for me. It absolutely broke my heart and continues to break my heart every day. And eventually I kind of had to give up what I thought my life was going to be and figure out a new path forward. So as this patient spoke to, this initiates a process of reconciling their hopes and their lived disease experiences, where there's uncertainty, layered upon uncertainty, right, about their own health, about if they can be the parent that they want to be, about the genotype of a potential child and what the physical manifestations might be of that child, and also the role of future treatment. Undoubtedly, assistive reproductive technologies are a very important part of the story for some of our families, but I wouldn't say that most of our families utilize these technologies when going through the deeply personal process of planning for a family. Let's see. And so I'm going to circle back here to sort of this question about how we've triaged at the at our sequencing program at NIAID at the NIH Clinical Center. So we see around 1,500 participants a year. 2/3 of those patients are self-reported white, non-Hispanic, and the vast majority of them consent to sequencing, and per survey have very little decisional conflict about that. You know, there's some important caveats there, but that's generally the bottom line. Per survey, most correctly identify limitations to genome sequencing, yet err on the side of being overconfident in the technology. And additionally, most receive negative results, which sort of creates an interesting group of people to think about and listen to a little bit more. So,
2 minutes, Morgan.
Thank you. So just to highlight some of the work that our genetic counseling team has done to think critically about, you know, ways that we can mitigate misinterpretation and sort of best use our efforts. We did a series of projects over a number of years to, one, confirm that the patient portal is a nearly useless way to communicate with patients about the results of genetic testing. Nobody sees it, nobody reads it. And then create a educational website and a link to connect to a genetic counselor if you had additional questions, then evaluated this tech and touch approach with a survey over this past summer positively. And so exactly this type of sort of iterative quality improvement, innovation to our practice with real life outcome data with patients who are prospectively going through the process that lets us continually inform the way that we're providing care and triage, you know, the high touch and low touch use of genetic counselors across patients who have either more complex genetic test results, genome results, perhaps a primary finding, secondary finding, and pharmacogenomics that's relevant for their care, like Magda's going to share a case of tomorrow, and then those who do just fine with an email update and aren't identifying themselves as having more need. So to wrap this up, I think there's a number of just very reasonable opportunities in the short term. One of the things that I think, so there's an opportunity, I think, to discuss patient engagement and the role of the advocacy community in this implementation work. And I think they're obviously key stakeholders and have already done some great work in this area that others in this room can speak to more. The next thing that I want to say is that for genetic counselors specifically, I think there's two really easy wins that are within the sort of framework provided by our national society, sort of situated in our national conference. And then there's also a practice resource that doesn't exist for immunology that Natalie Deitch from NHGRI is organizing among those of us who work in this area, which I think are great resources that don't exist today. Telehealth is going to continue to be a key factor for the issue of distribution. And then the last thing that I wanted to say that has felt like a gap to me that we were talking a bit about during the break is not actually having a very a data-based understanding of who is receiving genetic testing across the country and who's the ordering provider. And I think that data is available through some of the big commercial genetic testing companies. I have an impression, I know what happens at our institution, and I have an impression or an understanding about some of the other big academic medical institutions, but I think there's better ways to answer that question to inform our implementation strategies. So that's really all I wanted to say. I'm going to shout out the people on our team, the folks that support our work, and of course all of the patients and their families. So thank you guys for your attention.
All right. This is open for discussion and your comments and questions. I think, Bob, I see your card up. You want to go ahead?
Hi, thanks. Morgan, I had a question for you. Do you guys offer secondary findings in your genome, and what's your uptake? 95%.
I know you are not that tired. Yes, go ahead.
Sorry, I didn't catch the answer to that. So yes, you offer them, and yes, there's uptake?
Yeah, that's right. In our program, we offer everyone genome sequencing, and that genome sequencing is actually an all-in. There's not an opt-out to our research program for, you know, you get the whole genome and you get primary finding analysis, and you'll also get secondary finding analysis. So there are other pathways to genetic testing for people who really don't want secondary findings. And for some people, that's the case. I find it more common for the people who end up at the NIH Clinical Center that they're upset that we don't return more types of results.
I think our experience in Invitae for whole exome was 95% of people said they were given the option
Yeah.
and they took it. They wanted it.
Yeah.
Yeah, thank you. Thank you for that. So my kind of a question, a comment. One is I live in a rural state without much support for genetic counseling, and so I wonder about how available this kind of support is for patients and what you see the major gaps are for making this more widely available. So that's one thing. And then the other thing, the time of sort of getting information and then coming to some sort of acceptance of this is my new reality. Are there strategies that you talk about for how to help somebody come to that point of acceptance? Is it just really so individual that there are no strategies that you can apply generally, or are there?
Thanks, those are great questions. Yes, I'm also from rural America, so it's a question that's near and dear to my heart. The genetic counselors, like a lot of other specialty care, is absolutely concentrated on the coasts. There's, I think, been some good progress in this area over the last many years, accelerated by the pandemic and telehealth. And there are some companies, including Genome Medical, which employs a whole bunch of genetic counselors and can, provide genetic counseling every day of the week, paired with genetic testing that's available through their company. And so I think it's a reasonable way to close the gap for some of those, for some of that need. But I'm very sympathetic. I know that there's, right, and different pathways, right, that there's, where I'm from, it's like, well, if you're willing to drive to Omaha, there's a guy that has a 9-month wait list that's willing to see you, who sometimes has a genetic, so it's just like the access issues are really big. So I think that telehealth is probably one of the best approaches. And then, how do you help people adapt to their illness? I think that's a really deeply felt and special question that I appreciate. I very often approach that with, what's been helpful and what's been less helpful so far. What strategies have people used to sort of like come to come to reconcile themselves to the limitations or opportunities that they find with their health. And people very often are eager to talk about this and have a lot of observations and personal insights about what exactly that has been for them. So I find it less that I'm telling them what they need to do and that they're telling me what's been helpful and where they see, I ask people sometimes, how is it different 5 years in the past, and how do you imagine yourself being different 5 years in the future on the inside? And people have a lot to share about what they've learned about themselves and what they've learned about their world and about their community and who's there to help them. And I think people very often, not everyone, I think some people struggle quite mightily with this, and I think, comorbid depression is really an important part of the equation for some of these patients, where it's really hard to find a sense of hope. There's really hard to imagine a future that they feel good about. But very often people have quite a lot to say and quite a lot to draw from. You hear these stories, or even just like in the case pictures, people have been through a lot and learn a lot about themselves in the process.
Do you think a lot of people feel like they're the only one, and that through these, support groups
Yep.
with people who are going through the same thing
Yep.
is probably one of the beneficial ways to help people cope?
Yeah, absolutely. And reviewing some of these patient quotes and preparing for this discussion today, I absolutely saw just so many people saying, for years and years and years, I was the only one I knew that had anything like this. And it was really helpful to talk to someone who knew what I was talking about. And again, talking about the advocacy communities, I think the Jeffrey Modell Foundation, but also the Immune Deficiency Foundation has been a great player, and the patients are very engaged, dedicated, passionate about their stories. I think there's a lot to leverage there.
We have two cards, the other end of the table, but maybe before you start, Carol and Morgan, I just want to say I appreciate the question and the responses. And maybe if we could capture for the report that comes out, in addition to the huge challenges you mentioned in the rural areas, I've recently learned that in urban centers, in the inner cities of our major urban centers, there are deserts for these services as well. We really should be take care of that. Let's start with you and both, and then we'll come back to Ephraim.
So I have a question about the various sort of diagnostic testing strategies and the biomarkers and the predictors. And it sort of gets to the question of how all of that information is going to be documented and stored in the chart, right? So we have this problem in genetics that a lot of the genetic testing reports come back as a readable PDF, but you can't compute on it, and so you can't get structured data. And so there's this push to try to get genetic data into structured form that you can then use for learning purposes and quality improvements. So for the biomarker test, it looks like there's a bewildering array of possible products. All of them have different outputs, different, tiers of 5 bands of predictors and all of that. So is there a vision for how all of that gets structured so that in an EHR system, you could drive decision support off of it?
Yeah, so it's probably a lot simpler than it is with genetic data, just because a lot of these do consolidate all of that information into a single score, but then there's interpretation that comes with it. And presumably as clinicians get used to using a particular test, that it will become a little bit more easy for them to assimilate. It's also unlikely that one particular hospital is going to have 4 different tests for bacterial versus viral discrimination, each with their own numerical ranges and so on. So you'll have one that your site uses and you get used to that. And so there isn't that complexity. It's not like you'll have one test, but then if you're looking at this condition, it's this, you should be looking at this component. And if you're looking at a different kind of a patient, there's something else that you should be looking at. There's still a fairly, these multivariate index assays, there's sort of precedent behind them. So it actually shouldn't be that difficult. And all these instruments are intended to integrate with LIMS. You're not sending this off to a reference lab and then getting your result as a PDF that you then have to figure out how to integrate. So a lot of it is going to be streamlined in that respect.
Thanks. For the gene expression tests, it seems to me that from the data we saw today that we need to have more underrepresented populations and participants as part of the development of those tests and eventually the perfection or the optimization of the models. And when I say that, and I'd love your thoughts on this, I think it needs both individuals that are diverse in terms of self-reported race and ethnicities, because those may be reporting on exposures that could confound the gene expression data, and genetic ancestry, a diversity of genetic ancestry, because those also may directly impact the gene expression. So could you comment on the strategy there?
Yeah, no, absolutely. That's one of the things that we've been talking about for almost 2 decades now. Majority of the diagnostics fail because they don't generalize to broader patient population. That's the single most important reason. The advantage is a lot of data already exists. Now, specifically for gene expression, if you just go to Gene Expression Omnibus, there are about 5 million samples from different disease, different background. And with the advances in computational sciences, all of that data is now available for analysis. The focus, in my opinion, needs to be on making it more structured, like the clinical data sets are. And then one thing that we need to continue doing, that we've been doing for almost 3 decades now, is as these data are generated, NIH has done a wonderful job and continue to make sure that people put their data in, so that computational people like me can come in and account for this heterogeneity upfront. And it's not just one source, right? We basically need to worry about 3 sources of heterogeneity: biological, clinical, and technical. Different technologies, gene expression, we've gone from PCR and microarrays to now single-cell sequencing. So that's the technical part. Biological, we've been talking about the effect of age, sex, race, ethnicities, socioeconomic status, and then the clinical, all of the comorbidities that we've also been talking about today. And it's going to be very difficult for a single group to make sure that all of the real-world heterogeneity is in a single cohort. The best way to do it is for the community to come together and keep putting data out so that 5 years from now we can combine all of that.
I'll add to that if I may. So a lot of I think the strength of the approach that Pravesh has taken is to draw on that heterogeneity of data so that all of those different populations are represented when you do your discovery work. That isn't always available depending on what disease you're looking at. There may just be a sparsity of data or just not well represented. But going beyond that, there's also the importance of validating your test in the populations of interest, and that's absolutely critical. That has to happen. One of the inherent challenges, we could think about an idealized future where you have ready access to a transcriptome. For those who watch the movie Gattaca, right? You get your transcriptome in a matter of minutes from a finger stick or whatever the case is, and then you incorporate an analysis of that data in real time. That would be fantastic, incredibly complex, but that would be ideal. But unfortunately, that's not how our regulatory environment works either, right? You have to identify your biomarkers, lock them down, lock your algorithm down, which then is a barrier to any learning that happens as new information comes in. So I think there also needs to be potentially in the future a change in the way we think about how these multivariate analytes, particularly very high multiplexed or very high complexity analytes or tests, are thought of so that there is a learning component that gets incorporated that can take into account new diseases, new phenotypes, new discoveries, new understandings.
Bob, is that a new question?
Thank you. I had a question for Dr. Khatri. So ultimately, if this Influemix works well and it appears to be actually have clinical utility, in addition to validity, who do you think needs to be convinced to implement it? Is it going to be the hospitalists and the ICU docs, or is it going to be the lab medicine pathologists?
Well, all of them. One thing we are learning is different hospitals have different people that are ultimately making the decision. Our vision is this will be a test in ED, so that when you're trying to triage patients, this could be one of the tests that upfront tells you. And the way we think about this is, we think about different diseases leading to sepsis. But in ED, it's people coming in, and then we are saying which of them actually have infection. So that's where this would ideally be located to start telling people to basically triage.
My usual experience is that pathologists don't like other people doing laboratory tests. I mean, when I was an intern and a resident, I did my own urine analysis on patients when admitted. That's anathema now. They would never allow that to happen.
I'm not laughing at you. I'm laughing with you. Absolutely, that's been our experience as well. And I always tell people, you solve one problem, there will be next problem. And you just have to stick with it. It's, as Ephraim was saying earlier, it took us 10 years to get here, another 5 to convince people.
I think, Stephen, you still have a question? And then Terry and Jillian.
Yeah, I'm a little ticked at Terry Manolio because she wouldn't let me present the data that you presented, Ephraim. And that just doesn't seem fair.
You had far more important work to talk about.
She said it was too speculative or something like that. So, nah. It's my job to keep you all amused at this time of the day. All right, so I guess we're realizing that there's a heterogeneity of etiologies behind sepsis. There's this community acquired against a somewhat normal immune system versus immune deficiencies. I'm thinking that's probably contributing to some of the variability that you're seeing in these biomarker studies, is that the genetic substrate, the host substrate, which you're measuring, is very different. in a heterogeneous manner. I'm not sure how to reconcile that, right? I'm not sure how these if we're thinking about an integrated future solution for sepsis, I'd love to hear how you're thinking about that. Clearly for targeted therapies for immune deficiencies, we want to pick these things up early and we want to jump on them real hard. So they're going to get quite different therapies when they present, say, with SIRS or whatever. So for both of you, I'd love to hear your thoughts.
So sepsis, I would say, has two major components. There's the pathogenic component, the pathogen component, all of which is going to be treated with antimicrobials, and it's a matter of figuring out the right one and narrowing in and using all of the standard microbiological tools that we have at our disposal. The other one, which is the one that so far we have failed to mitigate, is the dysregulated immune response, which exists, that's in the definition of the sepsis. And the way in which it's dysregulated, that's where all of that heterogeneity comes from. It may very well be that people are immunosuppressed. Although interestingly, patients who we know have immunosuppression for transplant or that sort of a population, they often have better outcomes when they develop sepsis because they're more susceptible, but they also don't have the runaway immune system that others do. And so, I don't know that we're going to ultimately see success by kind of labeling a patient as being immunocompromised or hyperimmune. They're all maladaptive in some form or another. And what I'd love to see ultimately is where we start to, the labels are less important, but what are the groupings? What are the abnormal biological pathways? And if we can understand those, then we could potentially identify therapies that target them. Some patients might need an immunostimulating agent. Some might need an immunosuppressive agent or immunomodulatory agent. Maybe in some cases it's the JAK-STAT pathway that needs to be manipulated, or in others it's a different pathway that needs to be modulated. So as we get greater and greater granularity, I think that will open up the opportunities for what we do for these patients. One of the other things that makes it really challenging is these are dynamic. What we know from some of those subtyping studies is patients may be in one category one day, and 48 hours later, they're in a different category. But that trajectory is also meaningful. The patients that start off in a bad category and stay in that bad category do very poorly, much worse than people who start off in a bad category and then improve to a better one. So the trajectory, the kinetics is also informative. So these are not all necessarily inborn and static and constant. Again, they are in certain scenarios. But for most patients with sepsis, these are highly dynamic and changing, which makes it hard.
So only one of us should have been here today. We are like-minded. That would have been mostly my answer as well. And then the other thing is, again, I'm going back to Roshni's slide. It was a second or third slide where genetic background was one of the 11 or 12 different factors that she had. And I think Priya also talked about it earlier today. Correct me, Priya, if it wasn't you, but she mentioned how it was a single strain of COVID, but there was huge variability in the outcome. So we are never going to get this experiment ever again, right? This was the best natural experiment we could have, as a scientist, hoped for. And that tells you, and then the other thing that came out of COVID literature is, despite all of this heterogeneity across all of these countries and all the age and comorbidities, the immune response that was triggered in response to COVID was always the biggest magnitude. Everything else was much smaller magnitude compared to the antiviral response. And that speaks to what the immune system has learned over time. That yes, you are going to have all of this heterogeneity, but once there is an insult, there is an infection, that's going to take over. And that's what, at least for Triverity, we've been able to see that you do see a lot of heterogeneity, but ultimately what defines whether you would have severe outcome or not, that's the host response. I would also go back to something that Ephraim was talking about, these endotypes or the different subgroups. we are seeing that if you don't have all the patients with exactly the same immune dysregulation within sepsis, ARDS, burn trauma, all of that, you actually see patients with either only myeloid dysregulation or only lymphoid dysregulation, and you can actually quantify that. And then there are patients who have both myeloid and lymphoid dysregulation. And depending on that, you can start making hypotheses, and we have data on bioRxiv that actually shows that based on the type of immune dysregulation, you can predict what would be the drug that patients would benefit with. And then in longitudinal studies or randomized control trials, we can actually show that the patients who benefited from certain treatment, that was because they were treated with the drug that targets the immune dysregulations that they have. So that probably is where the field is going to go in the next 5 years to 10 years.
So I'm going to change the topic. And so Scott, if you were going to speak specifically to this area, you want to go ahead?
Sure, thank you. I think the worst thing that happened to sepsis is the term sepsis, and I think every time I listen to a sepsis biomarker talk, it seems like everyone's just running away from the word sepsis, and then at the end we come back to it. And so I want to know, like, how these biomarkers that you're measuring are not diagnostic biomarkers. They're measuring specific physiologic defects. And rather than defining sort of AI-generated endotypes that don't actually help anyone describe anyone's physiologic state and time, is there a utility to, you know, using these biomarkers to pull out maybe more like, this looks more like a antiviral response versus a intracellular bacterium versus an extracellular bacterium versus a fungal pathogen versus a tissue damage versus DIC, TMA, all of things are happening at exactly the same time dynamically, and we just call it all sepsis. And then we revert back to algorithms and endotypes, and then we wonder why we can't get anything to work in sepsis. So how are the biomarkers going to help people to understand the physiology as opposed to sort of just bucket algorithm and knee-jerk response?
So you're absolutely right, and again, that's sort of that future state where I think we start to create layers, and you can use the host response to infer what the pathogen is. So you know, the bacterial versus viral stuff, and we have gene expression signatures to indicate the presence of a fungal infection. So to some extent, that exists in the research space, at least for now, and starting to emerge in the clinical space. But measuring host response and then saying, oh, okay, this is consistent with a bacterial infection. This is consistent with a fungal infection. So that, in theory, is doable. Now, if you could measure an entire transcriptome in a given patient as opposed to selectively measuring a handful or you know, a couple dozen mRNAs, now you could start to create those layers. That, okay, I see a bacterial response here. I mean, you need the models to identify those. And it looks like there's you know, this particular pathway is activated and that pathway is activated, or that one is repressed. So as you have more information available to mine, and you can measure it in real, I mean, the other thing to realize is that with sepsis, you've got to make decisions in a matter of minutes to hours. You can't send a specimen off and then come back a week later and then decide what you're going to do. So that is an inherently limiting aspect to it. But the other place that we're starting to go away from the term sepsis is to identify treatable traits, right? So Pravesh alluded to sepsis, trauma, burn, ARDS. We're identifying, it's still not a very granular level, but these hyperinflammatory, hypoinflammatory, it's not great terminology, but it's painting with a very broad brush. But that actually seems to transcend these different conditions. So it doesn't matter whether or not your critical illness was triggered by burn or pathogen or some other trigger. There's a lot of commonality in that biology, and I think that also opens up a lot of opportunity for therapeutics. And then there's also the identifying a very specific pathway with a particular biomarker. This biomarker identifies endothelial dysfunction, and based on high levels of this one biomarker, I know that I need to treat with drug X to target that underlying biological pathway. So it's going to be piecemeal to start off with, and I think that's largely because of limitations in our technology.
And I would just expand on that. I mean, think about breast cancer, right? 5-year survival was abysmal, but then we started with HER2 positive and EGFR positive, and we have 3 mutations, everything else, triple negative breast cancer. And then even further subtypes in that, and now we have over 90% 5-year survival in breast cancer. So it's not going to happen overnight, but these endotypes, you're starting with one, and then incrementally improving that is how it's going to happen.
And speaking to this point too.
Well, and actually, I was just sort of taking the step back to the clinic. So say I get the result from this test, and you know, how do you take the readout from the test to the patient? and I think everybody knows that the risk of sepsis is your patient can die. Well, maybe is that a 1% risk or 5% risk? And you're telling me there's a 10% risk of sepsis, or maybe it's a 5% risk. How's that going to change my treatment if I actually have a, you know, what geneticists say is a very high burden problem here if it's a potentially lethal disease?
So I would point to some of the data that I presented, right? So there is a risk of somebody dying and not knowing what's going to happen. And one of the best results that we found was we were able to pick up false negatives. So the current clinical practice that is saying all your test looks good, you are not showing any severe symptom, we are sending you home. And in those people, we were able to pick up 77% of the people that shouldn't have been sent home and should have been sent to ICU or at least observed on the floor. That is first, my hypothesis is that's what's going to start convincing clinicians that we are actually saving lives and not missing. There is no diagnostic that's perfect. Even if you look at the FDA data for the errors in emergency department within US, the error rate in emergency in US every year is about 6%, right? So getting to 100% is very unlikely to happen. But being able to pick up these false negatives, start saving those lives, is going to start convincing more people, and also going to tell us how to improve our diagnostic at point of care.
So basically, you're saying let's use it to include more people, but never to exclude treating people. Is that right?
I think that's one thing. If you ask sepsis, and Ephraim and other people can correct me, I'm an electronics and communications engineer, right? So I'm not the phony, I'm the phony doctor, PhD, right? The PhD, PhD. But the threshold for giving somebody antibiotic is very low anyway, suspicion of sepsis, and its empiric treatment. And what a lot of the clinicians have told us is, who should we not be treating, because we know that we are treating a lot of people that should not be treated with antibiotic.
Right, Terry has been a terrific timekeeper all day, so I'm going to say it before she says it. We have 10 minutes to go, and we may have 2 or more questions, and so brief responses to the questions so we can get all of you out of here on time. Terry, over to you.
Great, thanks, George. I do have to channel Steve Holland, who is dealing with an outbreak along with Jeannie, but they will be back tomorrow. Steve did make a comment early in our deliberations about the fleets of ships that have been wrecked on the shoals of sepsis research, which is, something to a cautionary tale. But I wanted to change the topic a little bit, and if Roshini is still with us, and very much appreciate your joining us in the midst of an acute illness. You mentioned a lot of concerns about the regulatory environment and how that may change. And we do have a session tomorrow, if you can join us, that Jillian will be leading, that will be looking at that somewhat. But I would ask you, Roshini, do you have suggestions for the kind of research that might be helpful to the regulators to actually make decisions that align with the science?
Before you answer, can I tack onto that? Because I was going to ask a very similar question. with a slightly different observation as well, which is I also thought your comments were really interesting about the FDA and the way that it may change things for the LDT space. And I thought it was interesting in contrast, actually, to the next two speakers who really spoke about the FDA as somewhere between just a necessary part of the process, I don't know, or necessary reality of life, to even sort of hinting at it as a pathway to access with the FDA. And so that struck me as a conflict. So I'd be interested actually in all three of you sort of weighing in on the FDA and where that stands.
Thank you, Terry and Gillian. I hope you can hear me. And I will be at the session tomorrow. But Terry, currently as we've been preparing for the initiation of the FDA regulations, what I have heard time and again is the FDA is concerned about quality, about clinical utility, and clinical efficacy, if you will. And if you recall, the LDTs had FDA guidelines as well regarding analytical validation, that you had to meet certain analytical parameters in your validation to implement your LDT. And that's partly what added to the cost and the rigor and the time for validating a LDT properly. And the FDA is concerned that clear license holders who are not CAP accredited are taking shortcuts, both in analytical and clinical validations, and that it's not equal across the board, across clinical laboratories. And I think to some extent the FDA is correct, but a lot of their phase 1, 2, and 3 is related to how are you going to deal with complaints? How are you going to correct if there's a mistake? How are you going to register your test? So at least for the first 3 years, it's a lot of quality assistance essentials, as well as a lot of things to do with reporting and ultimately about the clinical utility of your test. The challenge, Terry, I think, is that it's already costs us anywhere from $150,000 to $250,000 to do a proper LDT validation, development, pre-development, development validation before bringing to the clinic. I don't think we, in an academic medical center setting, can afford additional time and money to be invested, and that's where the pushback is coming from our domain. And the other problem is that the FDA considers those of us in the academic medical field to be device manufacturers, and so puts us on the same footing with Ephraim and Purvesh, who have a different approach to this. And I don't think you can lump us all into that same category. And Gillian, I hope to some extent I answered that. If not, I'll try and re-answer your question.
Great. No, that was helpful. I think Ephraim and Pravesh, if you want to comment.
Yeah, I think, Roshni's point well taken, but the reason we chose that we need FDA approval, it could have been lab tests, right? One is the scale. If you really want to have an impact on a large scale, FDA approval is required. Hospitals do want to have that FDA approval so that they can administer tests to the patients. Second one, as Roshni was saying, people might say they might be taking shortcuts. And then the third reason, this FDA approval process where we have to do registrational trial, present our data, make sure everything is right, is what Jennifer was alluding to, knowing what is the risk. When we say there is 10% risk, there is data supporting it, and it's not just some made-up number. So all of these reasons require that there is, and it cannot be the company that's going to make money that should be certifying these numbers. It should be a third party making this decision.
I don't have a whole lot to add other than, I'd say that what I've appreciated about the FDA is that they've been, I think, reasonably progressive in terms of how they think about new diagnostics, and they really are trying to find a pathway, recognizing that things are dynamic and changing, but nevertheless, they still obviously have processes that they need to utilize in order to make sure that anything that gets through is essentially meeting the expectations. So, but yes, you know, an LDT route is not feasible for most of these diagnostics, just by how LDTs are defined. It's just, unless you expect your sample to be sent to a single lab, like Carius, right, with plasma cell-free DNA sequencing. You send your sample there. They're not trying to put a sequencer in every single lab. Maybe that is actually an ambition of theirs, but you know, there are certain tests that are amenable to an LDT format. But if you want to get your test result back within the time that the patient is still sitting in front of you, it needs to be deployed at the site of care. And if you have a commercial manufacturer of that test, the only pathway is through the FDA.
And I'll add one more thing. That was the Bayesian, all diagnostics are Bayesian, as Ephraim was saying. Ultimately, clinicians, just the sheer number of patients and the amount of work they have, they want some sort of algorithm, an FDA approval where we go through exactly what the thresholds are, how that provides that standardization to make decisions at point of care.
Well, and I might just add, George, because we do have 3 minutes, that it sounds like this may be a role for public-private partnership, or or academic and commercial labs, which there's always sort of this tendency. Oh my goodness, if an academic lab is commercializing it, they're only out for profit, and really it may be getting the adoption and the testing done that can't be done in an academic setting. So something to think about.
All right, we'll yield back 2 minutes to you, Terry.
Great, thank you from the gentleman from NHLBI. So great, we are just about done. I would remind the members of the Genomic Medicine Working Group, you are not done. We will be meeting at 6:30 at 7th State, which is 7701 Woodmont, just up the road. So please be prompt. And tomorrow we will be starting at 8:30, not at 9. So breakfast is at 8, and then we'll start again at 8:30. And any other announcements? Yes, Gail. Oh, I'm so sorry. It's 6? Okay, it's good that I have Gail and Alana here. It is 6 p.m. My sincere apologies. So we'll see you all there at 6. And I think that's
Terry,
it.
I'll gargle cough medicine for you.
Sorry?
I will gargle cough medicine for you.
Oh, okay. Thank you. I appreciate it.
And I'll be playing Christmas songs.
Okay.
Good time.
These poor people want to get to their rooms. Yes, Gail? I don't know. All right. Thank you all very much.